Welcome back to the deep dive. Today we are not just looking at anatomy, we are looking at what I like to call high-stakes real estate.
That's a great way to put it.
We are talking about a part of the body that is, often dismissed as just the end of the line. It's unglamorous, it's often the butt of the joke, pun intended, but surgically, it is a minefield.
Oh, absolutely.
It's a zone where anatomy, oncology, and quality of life all collide in a space of about 15 centimeters. We are talking, of course, about the rectum.
It really is a fascinating anatomical battleground. People tend to lump the rectum in with the colon, but surgically they are worlds apart. The margin for error in rectal surgery is incredibly small.
How so?
Well, you're working in a confined pelvic basin, surrounded by nerves that control bladder and sexual function, and you're dealing with a tube that has very specific, unforgiving rules regarding its blood supply and lymphatic drainage. If you don't respect the anatomy here, the consequences for the patient are life-altering.
Exactly. And to guide us through this terrain, we are diving into the absolute gold standard text. We are unpacking Baily and Love's Short Practice of Surgery, specifically focusing on Chapter 79, the rectum.
And we are looking at the 28th edition here.
Right. And for anyone listening who thinks, okay, how complicated can a tube be? The answer is terrifyingly complicated.
It's deceptively simple looking, but as we go through this, you'll see that every single centimeter counts.
Right. Now, a quick mission statement before we get our hands dirty, figuratively speaking. This deep dive is designed as a ready reckoner.
Yep.
It's an interpretive guide for medical students, surgical trainees, and the insanely curious. We want to help you visualize the concepts so they lock into your memory for exams and for clinical practice.
But, and I have to stress this conversation is a companion, not a replacement. Baily and Love is dense with fine print and incredibly detailed diagrams that you need to see with your own eyes.
So true.
We're here to give you the mental framework, the skeleton. You need to go back to Chapter 79 to put the flesh on the bones.
Consider this your audio roadmap. So here's where we're going. First, we're going to map out the anatomical envelope, the battlefield.
The battleground, yeah.
Then we move to clinical detective work, how to assess the patient properly. After that, we get into the pathology, trauma, prolapse, inflammation, and neoplasia.
Then we've got some check-ins along the way.
We do. We've got some case studies and interactive check-ins to make sure you're actually retaining this.
It's a full itinerary. Let's get into it.
Let's start with the structure itself. Section 1, surgical anatomy. Now, looking at the text, the rectum is described as a tube, roughly 12 to 18 centimeters long. But my first takeaway from reading this is that treating it like a straight pipe is a disaster waiting to happen.
It is a rookie mistake, a classic one. If you want to master rectal surgery or even just safely perform an endoscopy, you need to anchor your understanding in the rule of thirds.
Okay, the rule of thirds.
Imagine that 15-centimeter tube divided into 3 distinct parts.
Yeah.
The upper, middle, and lower thirds.
Why does that division matter? Is it just for labeling or is there more to it?
It matters because of the peritoneum. This is what I call the peritoneal trap. The relationship between the rectum and the peritoneum changes drastically as you go down.
Okay.
In the upper third, the rectum is covered by peritoneum on the front and the sides. It's fairly mobile.
Right.
In the middle third, the peritoneum only covers the front. But, and this is the critical clinical nugget, the lower third is completely naked. It lies entirely below the peritoneal reflection.
Okay, let's unpack this. Why is that clinical gold? Why should a listener, really care about the peritoneal reflection?
Think about a perforation. Say you're doing a scope or there's a trauma and you poke a hole. If you perforate the upper rectum, you're spilling bowel contents into the peritoneal cavity. You get generalized peritonitis.
Which looks like what in the ER? What's the presentation?
It's loud. The abdomen is rigid, board-like. The patient is in agony. They're in septic shock. It's a screaming surgical emergency. You know exactly what has happened.
Okay, so upper third equals explosion. A big, obvious problem. What about the lower third?
Well, if you perforate the lower third, that leakage goes into the extraperitoneal pelvic space. You don't get peritonitis because you haven't breached the peritoneum.
Oh.
Instead, you get deep, insidious pelvic sepsis. The abdomen might be soft. The patient might just feel unwell or have a low-grade fever. It's a slow poison.
That is terrifying. So the anatomy dictates the catastrophe. And if you miss that lower third injury because you're waiting for a rigid abdomen,
you might lose the patient. Precisely. If you remember nothing else from this anatomy section, remember that the lower rectum is naked, and injuries there, hide in the shadows.
Wow. Okay. Now, you mentioned it isn't a straight pipe. It has curves.
Two types of curves. First, you've got the sacral curve, which just follows the shape of the sacrum, bone concave forward. That's pretty intuitive.
Sure.
But then you have the lateral curves, and these are marked on the inside by folds called the valves of Houston.
The Valves of Houston. Sounds like a rock band or maybe a law firm.
Less musical, unfortunately. They're usually three, and I use a driving analogy to remember them. Think of driving a car down the rectum. Sorry for the mental image.
Go, buckle up. Go for it.
You steer right, then left, then right. The upper and lower curves are convex to the right. The middle curve is convex to the left.
Right, left, right.
Exactly. It's a slalom. And this isn't just trivia. When you're passing a colonoscope, or especially the old rigid sigmoidoscope, which is, straight steel,
Right.
you have to navigate these turns. If you just jam the scope in straight, you are hitting the wall, specifically a valve of Houston. You need to know how the road bends to navigate it smoothly.
Okay, navigating the road. Now let's talk about the walls of the tunnel. The text mentions these critical fascial layers. I have heard this described as the oncological envelope. This seems to be the holy grail of rectal cancer surgery.
It absolutely is. It's everything in rectal cancer surgery.
Yeah.
We are talking about Denonvillier's fascia and Waldeyer's fascia.
Let's break those down for a second.
Okay, so Denonvillier's fascia is anterior. It's the tough, shiny barrier separating the rectum from the prostate and seminal vesicles in men or the vagina in women.
Got it. Anterior.
And Waldeyer's fascia is posterior, separating the rectum from the sacrum and coccygis.
And why are these the holy grail? Help us visualize the relationship between the tube, the fascia, and the cancer.
Because they form the boundary of the mesorectum. The mesorectum is the fatty tissue surrounding the rectum that contains all the lymph nodes and blood vessels. We use an analogy here. Imagine the rectum is a letter, and the mesorectum is the sealed envelope it comes in.
Okay, a letter in an envelope. I like that.
When you're operating on rectal cancer, the cancer cells and all the microscopic spread are inside that envelope. If you tear the envelope, if you breach the fascia during surgery, you spill the contents,
Oh, no.
you leave cancer cells behind. The whole goal of total mesorectal excision, or TME, is to remove the envelope completely intact. You want to take the letter out without ever opening the seal. That is how you cure rectal cancer.
That is such a powerful visual. It completely shifts the mindset from cutting out a tumor to removing an entire sealed compartment.
Precisely. And knowing where Denonvillier's fascia is anteriorly prevents you from accidentally cutting into the prostate or vagina. It is your shield.
Okay, so let's talk about the plumbing, the blood supply, and the drainage.
The arterial supply is fairly straightforward. You've got the superior rectal artery, which is just the continuation of the inferior mesenteric artery. Then the middle rectal, which is variable, and the inferior rectal. But the lymphatic drainage, that's where the so what really lies.
The text mentions the flow is usually upwards.
Correct. The river flow of lymph is normally upwards along the superior rectal vessels to the periaortic nodes. That's the path of least resistance.
Right.
But I want you to visualize a dam.
A dam.
Yeah. If a cancer blocks that upward river, if it creates a dam, the lymph has to go somewhere, so it reverses flow. It starts draining laterally to the internal iliac nodes on the pelvic sidewall, or even downwards to the inguinal nodes in the groin.
So, if you are examining a patient with a known rectal cancer and you feel hard, enlarged lymph nodes in their groin,
It's a very bad sign. It implies the upward path is totally blocked. It means the river has flooded its banks. It usually signals late-stage, widespread disease.
that is a grim but very effective way to remember it. It's basically a hydraulic system telling you how bad the blockage is.
That's a great way to think about it.
Okay, before we move on to assessment, we have our first interactive check-in. We are going to test your retention of the envelope.
Right. Listen closely. This is a key point.
The question: if you are performing a total mesorectal excision, or TME, for a midrectal cancer, which fascial layer protects you from entering the prostate anteriorly?
I'll give you a second. Pause the audio if you need to think. Imagine the anatomy. You're operating. You're at the front of the rectum.
And the answer is?
Denonvillier's fascia. If you said Waldeyer's, you're on the wrong side. That's posterior. If you didn't get that, rewind to the anatomy section. This layer is your shield against a urological disaster.
Excellent. Let's move on to section 2. Clinical detective work. The text emphasizes that symptoms in the rectum can be, they can be really deceptive.
They can be incredibly subtle, and patients are often embarrassed, so they minimize them. The classic teaching is to ask about bleeding, but you need to ask, what kind of bleeding?
Right.
Is it fresh, bright red? That's usually outlet bleeding, like hemorrhoids. Is it altered dark blood? That's coming from higher up. But the real detective work is in the bowel habits.
Specifically, the text mentions spurious diarrhea. What is that?
This is a term every student needs to know. It is not real diarrhea. The patient complains of needing to go constantly, especially early in the morning, passing just small amounts of fluid. That fluid is often mucus and blood leaking around a solid obstructing cancer.
Ah.
It mimics diarrhea, but it's actually a sign of obstruction.
So spurious means fake. Fake diarrhea equals check for cancer.
Every single time. If an older patient comes in with new morning diarrhea, but they're straining, alarm bells should be ringing loudly.
And then there's this word tenesmus. It sounds biblical, but it's very physiological.
Tenesmus is the feeling of incomplete evacuation. The patient goes to the toilet, strains, passes nothing or very little, but still feels full. I call this the phantom poop.
Phantom poop, I like that.
The rectum feels full not because there's stool in it, but because there is a tumor mass occupying that space. The stretch receptors in the rectum are smart, but not that smart. They can't tell the difference between a tumor and a fecal bolus. They just signal the brain, we need to empty. But the mass isn't going anywhere, so the patient is in a constant state of needing to go.
That is such a distinct red flag. If a patient describes the phantom poop, you absolutely have to rule out a space-occupying lesion. Now, what about pain proctalgia?
Here's a pearl for you. The rectum itself is relatively insensitive to pain because it has visceral innervation. You can biopsy the rectal mucosa without anesthesia, and the patient won't feel sharp pain. Yeah. So if a patient has severe pain proctalgia, it usually suggests the disease has moved down into the anal canal, which is very sensitive, or it's invaded the pelvic floor muscles, like the levator ani. Pure rectal cancer is often painless until it's very advanced.
Which is exactly why screening is so vital. Let's talk about the physical exam. The text specifies the Sims position.
Left lateral, semi-prone. It's the standard safety position.
Yeah.
And we have to talk about the DRE, the digital rectal exam.
The finger.
The finger. You cannot be a colorectal surgeon, or a competent GP for that matter, without mastering this. Baily and Love is very specific here. USS tone. You feel for masses, you classify them. Intraluminal, inside the tube like a polyp. Intramural in the wall like a cancer. Or extramural, outside pushing in like a prostate or fibroid.
Right.
But the most important part of the DRE is what happens when you pull your finger out.
Looking at the gloves.
Look at the glove. Is there mucus? Is there pus? Is there blood? That residue is a diagnostic sample. Never waste a DRE by wiping the glove before you look at it. It tells you exactly what is happening upstream.
Good point. Moving to scopes, we have proctoscopy, sigmoidoscopy.
Proctoscopy is short just for the anal canal and very low rectum. It's good for hemorrhoids. Sigmoidoscopy comes in two flavors, rigid and flexible.
The rigid one is that 25-centimeter stainless steel tube. In an era of high-tech flexible scopes, why does Baily and Love still talk about the rigid scope? Is it still relevant?
It is. It's old school, but it's incredibly effective for getting exact measurements from the anal verge. If I say tumor at 12 centimeters on a rigid scope, I know exactly where that is for surgery.
Ah, it's a fixed ruler.
Exactly. Flexible scopes can loop and coil, so the measurements can be misleading. They can stretch the bowel.
But the flexi is better for the upstream check, right?
Correct. Flexible sigmoidoscopy is vital, especially for fresh bleeding. If you have a patient with rectal bleeding and you find hemorrhoids with a rigid scope, you are not done. You have to do the flexi to make sure that blood isn't washing down from a cancer in the sigmoid colon. You absolutely have to rule out proximal disease.
Because if the rectum is clear but there's blood coming from above, you are dealing with proximal disease. It narrows your search field.
Precisely. You found the source.
Let's transition to section 3, trauma. This section of the text is, well, it's pretty dramatic. We have injuries from falls, gunshot wounds, and the delicate matter of foreign bodies.
It is a high-stress area of practice. The mechanisms are varied, falling on a spike, impalement, sexual misadventure. But the immediate decision is always, is the abdomen rigid?
And if it is rigid?
That means the peritoneum is breached. Laparotomy. You have to open the belly, no question.
Okay.
But if it's not rigid, recall our anatomy lesson. You might have an extraperitoneal injury in that naked lower third. That is where a contrast enema or a CT scan is preferred to map the leak.
Now, let's talk about foreign bodies. The text mentions a specific physical challenge in removing smooth objects, the vacuum effect.
This is physics working against you. The rectum is a muscular tube. If a smooth object like a bottle or glass is inserted, the mucosa hugs it tight. When you try to pull it out, you create a negative pressure seal behind the object. A vacuum.
Like trying to pull a boot out of deep mud.
Exactly the same principle.
Yeah.
The harder you pull, the stronger the suction. You can't just yank it. You will tear the mucosa or break the object. And if it's glass, that is an absolute disaster.
So how do you break the seal? What's the trick?
You have to equalize the pressure. Sometimes you can pass a small catheter alongside the object to let air in behind it, breaking the vacuum.
Okay.
Sometimes you need general anesthesia to relax the sphincter, and sometimes you need an assistant pushing down on the abdomen from above while you manipulate from below.
Teamwork. And the text has a strict rule about what happens after retrieval.
Yes, this is the divert to heal principle. If the retrieval was difficult and there is significant mucosal laceration, you cannot just send the patient home. You need to perform a temporary colostomy. You have to divert the fecal stream.
You have to bypass the rectum entirely.
Right. If you let stool pass over those fresh, deep lacerations, they will get infected, and you end up with that catastrophic pelvic sepsis we talked about earlier. It seems aggressive to give someone a bag for a rectal injury, but it saves lives.
It's the divert to heal principle. Okay, let's move to section 4. When the structure fails. Prolapse.
This is a mechanical failure. The rectum turns inside out. But we have to be really precise and distinguish between the two types. Mucosal versus full thickness.
How do you tell them apart just by looking at the mass?
It is all in the folds. Mucosal prolapse is just the lining coming out, usually less than 4 centimeters. The folds are radial, like the spokes of a wheel.
Okay, radial.
Full thickness prolapse, or procedentia, is the whole wall. It's longer, and the folds are concentric, like rings on a tree or a target.
Radial for mucosal, concentric for full thickness. That is a brilliant visual anchor.
And it's important, because full thickness prolapse can contain a pouch of peritoneum, a hernia sac, essentially, which might contain small bowel. So it is much more dangerous.
The text mentions different populations, infants versus adults.
In infants, it's usually because the sacrum is straight. They haven't developed the curve yet. It's almost always mucosal and treated conservatively. You just push it back, fix the constipation.
And adults?
In adults, specifically elderly women, it's often associated with a weak pelvic floor, chronic straining, that sort of thing.
Before we get to the surgery, there's this really interesting entity called solitary rectal ulcer syndrome, or SRUS. The name implies it's just an ulcer, but the text calls it a misnomer.
That is a huge misnomer. SRUS isn't just an ulcer. It's a mechanical problem caused by internal intussusception.
Tell us.
Yes. The patient feels like they can't go because the rectum is literally plugging itself. They strain. They might even have to use a finger, what we call digitation, to pass stool. But the root cause is the prolapse, not the ulcer.
That brings us to the treatment decision tree, the frail versus fit debate. This is a classic surgical algorithm, isn't it?
It is the central decision in prolapse surgery. You have two routes, the perineal approach from below or the abdominal approach from above.
Let's start with the perineal approach. Who is this for?
This is for the frail patient, the elderly, high-risk patient who might not survive a major abdominal operation. The big advantage is safety. You can even do it under spinal anesthesia.
But there's a catch, I assume.
High recurrence. It comes back more often.
Right.
Because you aren't fixing the loose attachments deep in the pelvis. The main procedures are Delorme's and Alzheimer's.
Differentiate those for me.
Okay, Delorme's is like pleating an accordion. You strip the mucosa off and then stitch the muscle together to bunch it up. It's good for shorter prolapses.
And Alzheimer's.
Alzheimer's is more radical. It's an amputation. You literally cut the prolapse rectum off and stitch the ends together. You do an Alzheimer's for big strangulated prolapses.
Okay, so perineal is safer but less durable. Now the abdominal approach.
This is for the fit patient. You approach from the belly, pull the rectum up, and fix it to the sacrum. This is called a rectopexy. The recurrence rate is very low, less than 10%.
But there were historical problems here regarding nerves, right?
Huge problems. The classic rectopexy involved mobilizing the back of the rectum. We just learned that's where all the important nerves are. If you damage them, you cause sexual dysfunction and can worsen constipation.
So what's the solution?
The modern standard is the LVMR laparoscopic ventral mesh rectopexy.
Why is LVMR better?
Because you only dissect the ventral aspect. You leave the nerves at the back completely alone. It lifts the rectum, and it can fix an associated vaginal prolapse or rectocele at the same time.
But we have to address the elephant in the room. Mesh.
Yes, you have to. The Cumberledge report in the UK highlighted severe complications with vaginal mesh. However, it is important to note that LVMR uses mesh in a different position internally, not transvaginally. But the caution remains valid. You have to have a very frank discussion with the patient about the risks.
Okay, let's apply this algorithm with the case study. We'll call this the apple scenario.
Okay.
Picture this. An 82-year-old woman presents to the ER. She has a large red mass protruding about 8 centimeters from her anus. You look closely, and the rings on the mass are concentric. Her medical history includes severe heart failure, and she's on blood thinners. What's your move?
Okay, let's break it down. First, the mass. 8 centimeters long plus concentric rings equals full-thickness prolapse. It's not just mucosa.
Right.
Second, the patient. 82 years old with heart failure. She is frail. She's a high surgical risk. You do not want to put her under general anesthesia for a long laparoscopic abdominal case.
So the abdominal approach is out.
Correct. You go perineal. Given the size, 8 centimeters, Delorme's, the pleating one might be difficult. You would likely choose an Altemeyer's procedure, amputate the prolapse from below.
And the rationale?
It's safer for her heart, it fixes the immediate problem, and even if it recurs in 5 years, that is a trade-off worth making for her safety today.
Perfect application of the algorithm. Now let's do our second interactive check-in.
Ready?
A healthy 25-year-old man presents with rectal bleeding. On scope, you find a solitary ulcer 7 centimeters from the anal verge on the anterior wall. He admits he spends 30 minutes straining on the toilet every morning. Biopsies are benign, no cancer. What is the underlying pathology?
Pause and think. Ulcer. Straining. 7 centimeters up, anterior wall.
The answer is
Solitary rectal ulcer syndrome, or SRUS, and it's caused by internal intussusception. You don't just treat the ulcer, you have to treat the straining and the prolapse mechanism, often with biofeedback or surgery.
Moving on to section 5, the inflamed rectum, proctitis.
Proctitis is the great mimic. The symptom triad is frequency, loose stool, and blood or mucus. But the key takeaway here is you cannot diagnose the cause just by looking.
You need the lab.
You absolutely need biopsies and stool cultures.
Yeah.
If you mistake amoebic dysentery for ulcerative colitis and give the patient steroids, you could kill them.
Wow.
Yeah, steroids make the amoebas go wild.
The text mentions a few specific culprits. Obviously, IBD, ulcerative colitis, and Crohn's.
Right. UC usually starts at the rectum and moves up continuously. Crohn's is patchy. You might see cobblestoning, fissures, or deep ulcers with normal tissue in between. But there are 2 specific causes, Baily and Love highlights, that are fascinating.
Which are?
Radiation proctitis. This is huge, and we're seeing it more and more because cancer survivorship is improving.
Yeah.
A patient had prostate or cervical cancer treatment years ago. Now they have bleeding. The radiation damages the blood vessels. You get these fragile spiderweb vessels called telangiectasias. They just burst and bleed.
And the fix for that?
Argon plasma coagulation. Basically, you're zapping the bleeding vessels with a laser beam during a scope.
And then the infections. The text mentions bilharziasis.
Schistosomiasis. This is endemic in places like the Nile Delta. The schistosoma parasite lays eggs in the rectal veins. This causes a massive granulomatous reaction. You get these papillomas, finger-like growths, and fistulas. It looks messy, almost like cancer. If you're working in an endemic area, you have to think of this.
That brings us to section 6, the precursors, polyps.
This is the preventative space. Most rectal cancers start as polyps, and the rule of thumb here is really simple. Size matters.
The 1 centimeter rule.
Exactly. If a polyp is larger than 1 centimeter, the risk of it harboring malignancy jumps significantly. It needs to come out.
Let's talk about the types. We have hyperplastic, which are usually innocent, and then the adenomas.
Adenomas are the bad actors. You have tubular, which are the common ones, and villous. Villous adenomas are described as carpet-like, or having fronds like a fern. They're dangerous.
Why are they so dangerous?
They have a higher cancer risk, and they can secrete huge amounts of mucus. A patient can actually get hypokalemia, critically low potassium, just from the amount of mucus they are losing from a large villous adenoma.
That is wild. A tumor causing a major electrolyte imbalance just by leaking. And then there's the cherry tumor.
The juvenile polyp. It's distinct, seen in kids. It is smooth, red, pedunculated, so it's on a stalk, and it looks like a cherry. It's prone to bleeding or falling off, what we call autoamputation, usually benign, but very alarming for parents.
The text goes into detail about how we remove these. We have EMR and ESD. This feels like the frontier of endoscopic surgery.
It is. EMR, or endoscopic mucosal resection, is the standard lifting cut. You inject fluid under the polyp to lift it up, then you snare it with a wire. It works great for things under 2 centimeters.
But for the bigger ones or the flat ones?
That is where ESD, endoscopic submucosal dissection, comes in. It is essentially microsurgery through a scope.
Yeah.
You use a tiny knife to dissect the submucosal layer, removing the tumor in one giant piece or en bloc. This is crucial for getting clear margins.
But there is a safety check the text mentions. the non-lift sign.
This is a critical safety check. Before you cut anything, you inject fluid under the polyp. It should float up on a cushion of blue dye.
And if it doesn't?
If it doesn't lift, if it stays stuck down, that is the non-lift sign.
And that means?
It means the polyp is tethered to the deeper muscle layer. It is likely already an invasive cancer or it's scarred down from previous biopsies. You could stop.
Stop completely.
Stop! If you try to cut that with a snare, you will perforate the bowel. A non-lifting polyp needs a surgeon, not an endoscopist.
That is a vital stop and think moment. Finally, section 7, benign tumors and a brief look at carcinoma.
The text touches on some oddities.
Yeah.
Endometrioma, that's endometrial tissue invading the rectum, which causes cyclic bleeding with menstruation.
Wow.
Yeasts, or gastrointestinal stromal tumors, rare muscle tumors. And NETs, neuroendocrine tumors, or carcinoids.
And NETs seem to have a size rule, too.
They do, under 1 centimeter. Usually benign and indolent, you can watch them. Over 2 centimeters, they act like cancers and need radical surgery.
And speaking of cancer, the text wraps up by noting that the rectum accounts for 1/3 of all colorectal cancers.
Which is a massive burden of disease. And the red flags we mentioned earlier, that early morning spurious diarrhea, the tenesmus, the bleeding, those are the alarm bells. Baily and Love focuses so heavily on the anatomy and assessment here because if you get those right, the cancer management follows logically.
So we have covered the roadmap. We have looked at the anatomical envelope, the vacuum effect in trauma, the frail versus fit decision in prolapse, and the non-lift sign in polyps.
We have built the skeleton.
To wrap up, I want to leave the listener with a thought about the trajectory of this field. We talked about Alzheimer's, which is basically an amputation. We talked about TME removing the envelope. And we talked about ESD shaving off a tumor from the inside.
It's really a story of precision, isn't it? We are moving away from just cutting it all out towards reconstructing anatomy and preserving function. The shift from simply surviving rectal surgery to maintaining quality of life, sexual function, urinary function, continence, that's driven entirely by understanding that fascial anatomy we discussed right at the start. The envelope isn't just about curing cancer. It's about saving the person.
That is the big picture.
Exactly.
So your call to action, take this outline, go open Baily and Love, chapter 79, look at the diagrams of the Alzheimer procedure. They are unforgettable. Look at the cross-section of the mesorectum, put the flesh on these bones.
They keep asking why. Why is the pain there? Why is the lymph flowing that way? What is the anatomy beneath?
Thanks for diving deep with us. We will see you on the next consult.